Hi, everyone. My name is Haley.
And this is Laura.
And welcome to the Body Pod. Welcome, everyone. I have Dr. Tom Walters with me today, and we are covering, if you are watching this, his book, Rehab Science, which, Tom, I'm going to say, this is literally like my Bible. I have used it so many times. I think I told you I have a client that lives right by you, and we were working through some elbow tendinopathy. And I was so glad to see that I was doing most of the things in this book, but I was like, Tom, what do you think about this? Because these tendinopathies can take forever. So, before we get into that, let's go ahead and I wanted to touch on something that you said at the very first of your book, which is in many ways the rehab model is broken. So, can you tell us a little bit about where you started in your journey as a physical therapist and then what kind of led you to kind of doing your own thing?
Yeah, well, first off, Haley, thanks for having me on. This is amazing to get to. Thanks for buying the book and mentioning it. It really was the goal to create a resource that people could self-manage their own pain issues and injuries. Because most of physical therapy, right? There is a manual therapy. My residency was in manual therapy where I'm using my hands to work on people, and that can be good in the beginning for getting people out of pain. But most of the evidence revolves around exercise and movement, and those are things people can do on their own, and you can teach them in a book or some resource like that. So it's been so fun. It's been out for 2 years, and it's been really cool to see people using it in that way and kind of like solving things on their own. So, but yeah, thinking about the intro of the book, we start kind of talking about the rehab model being broken, and not that the interventions are broken and don't work, but just the model that it's delivered through. And I think anybody listening to this who has insurance and goes in the medical system with insurance recognizes immediately the limitations, and physical therapy is no different. We basically, physical therapists, I only lasted 2 years. I've been a PT for 18 years. I was only in an insurance model for 2 years because of just the limitations placed on you and how that impacts the quality of care that you can deliver. I mean, the clinic I was at was actually better than a lot of other clinics. We would see people for an hour when they first came in, and then every follow-up session was 30 minutes. So it actually wasn't bad.
Mhm.
But I had a lot of friends who saw people every 15 minutes. So you're seeing
Wow.
to 30 people a day. There's just no way you're really having enough time to talk with them about their symptoms, like all the back history that might be related to their pain. Like there's so many factors that go into pain: your stress, your sleep, your nutrition. Like there's no way you can cover that even in a
Yeah.
30-minute session. You just can't catch up with people. So a lot of physical therapists are kind of shifting out of the insurance model and going towards cash pay clinics and trying to figure out ways to better serve patients. But yeah, in terms of my background, I was an athlete all growing up. I was a martial artist and a gymnast, so I had a lot of which tied in really nicely with physical therapy because I was always barefoot, and I just
Yeah.
learned a lot of movement control, so a lot of body weight training. I'm really thankful for all those years in martial arts and gymnastics just because it really did kinda help me learn, sort of like applied kinesiology in a way. Like, kinesiology is
Mhm.
the study of human movement, and before I knew that term or what went into kinesiology, I kinda just learned about my body and how to control my body and how to strengthen it and all those things. And basically had knee surgery in high school. I had a not a real serious surgery. I actually had my kneecap. I was born with it in two pieces. It's called a bipartite patella, and
Mm.
it would hurt me when I'd land from jumping. Like in gymnastics, when I land, it would hurt on the front of my knee, and it was a very small little piece, and so I just had it taken out, and then everything was better, but I went to physical therapy after that, and so that was sort of my first exposure to using exercise to rehabilitate the body. I was always just used to performance and how do I get
Yeah.
stronger, jump higher, things like that. So then I did an exercise science degree, in college, so my bachelor's degree was in exercise science. I was really most passionate about exercise physiology, exercise science, and then went to in the US, you do a 3-year doctorate in physical therapy. You have to have a bachelor's degree, and then you go do that, and so I did that and mostly focused in orthopedic physical therapy, so it's all the common conditions people are used to thinking about, like back pain, neck pain, tennis elbow, plantar fasciitis, all these meniscus tears. It's like all the things most of us are gonna experience. So, yeah, that was kinda where I started and how I got into PT.
Okay. Well, I love it, and we're so glad that you now have this. I mean, what is your Instagram? You have like 1.5 million followers or something bananas. But when I started reposting, well, I mean, I'm so lucky. I don't even know how I fell upon you, but however I did, and I started following you, and then I posted something, and the people that I look up to most in this space, that like they all commented on my story, and they were like, "Tom is the best. I've been following him for years." So I was like,
That's
"Where have
amazing.
I been?" So let's dive in. Let's dive into the book. So
Mhm.
for the reason you wrote this book, as you kind of just talked about, when we look at it, and there are a lot of things outside of maybe an acute injury. Most of the women that I work with are coming in with chronic tendinopathies.
Mhm.
Outside of a skiing accident or something like that, some of this stuff, and I have a program called Foundation Happens, where we cover a lot of the commonly weak links that
Mhm.
nobody wants to target, because everyone wants to use the big prime movers and push pull and do the deadlifting and do the back squat, and they want to start lifting heavy, which the message is getting out to women that they need to lift heavy.
Mhm.
This is all great, but do it too soon, too fast, and every single time there's a tendinopathy.
Yeah.
So do you see this in your practice? And is there a difference between someone that's maybe 20 or 25 versus someone that's like 45, 50 and beyond?
Yeah, definitely a difference, and it's most of what I see in my practice too. It's mostly connective tissue disorders, tendinopathies, like you're talking about, especially for the people who are active or haven't been a lot very active and then suddenly get active. It's
Mhm.
usually tendinopathies. It's there. Your tendons and ligaments are connective tissues. So we kind of think of them generally as just connective tissue disorders. I mean, of course, some people do have muscle strains and other more severe injuries if something traumatic happens, but most people who are just kind of exercising and start to develop pain, it usually is a tendinopathy.
Mhm.
And it does come down a lot in the physical therapy world. We talk a lot about load management. So it's managing how much load you're putting on your system, how intense that load is. So like if you imagine you're going to pick up a strengthening program, if you just go and you haven't been doing any strengthening for ever or for the last few years, and all of a sudden you just go gangbusters and you're doing an hour of strength training every day, you're likely to develop tendinopathy. Or if you just pick up a running program and just start running you need to build into these things. Your musculoskeletal system has this great ability to adapt, but it's kind of slow. Your
Mhm.
cardiovascular system adapts a lot faster, so a lot of people get into trouble where it's like their heart and lungs can handle what they're doing, but their musculoskeletal system takes a little bit of time to catch up. And it's for sure different with age, like you mentioned. I'm 43 now. My body just takes a little longer to recover. It's easier for me to tweak something if I don't have a good warm up. I used to never warm up. I just jumped into
Yeah.
everything. So I think when you're in your teens and 20s, you see people will develop tendinopathy, but they have to really be pushing themselves, way higher volume. It's just, it's, excuse me, harder to trigger those kind of issues in younger people as we get older, and changes in connective tissue, changes in hormones, like all these age related changes. You just see way more tendinopathies, and they're just way easier to kind of flare up and get triggered. And I always tell people, the nice thing about tendinopathies is I would say they're seriously annoying, but they're not serious. Like it's not like an injury that you need to worry a whole lot about. In most cases, like you're going to tear something or something's really broken or damaged. It's just more that they're painful,
Mhm.
and that can obviously really limit you in life. So you have to figure out how to manage them. And a lot of that is kind of figuring out, how do I manage the load on my system, and can I kind of take baby steps, kind of break my exercise down into steps or gradually get into something so that I don't make those tendons kind of get angry.
Yes, and the muscle usually adapts much faster than the tendons and the
Mhm.
ligaments, and I think that, at least from my view, this is what happens is, people are feeling great, and they're getting excited and they're motivated. So a lot of women at this age are coming back from having children, having jobs. Now they're dealing with aging parents. There's 9 million things. And so they're finally coming around to making themselves a priority again. And so there is this excitement and motivation to get back in and start training, and they're hearing these messages. But I'm always, on my app, like, slow down.
Mhm.
Like, if we're in this for life,
Yeah.
sure, a tendinopathy might not, be something that is going to completely sidetrack you forever, but it's a setback. And as women at this age, if we can avoid setbacks to
Mhm.
the best of our ability, let's avoid those setbacks. So, do you ever look at, like, if you see people once that they have the tendinopathy, but is there like a prevention strategy where, like, some prehab that you would say, oh, if people just did this for this elbow tendinopathy or whatnot, you could probably save a lot of these tendinopathies that pop up?
Yeah, for sure. There's a ton you can do. I think at a base level, it is sort of like the accessory complementary type strengthening exercise, as you mentioned. Tendinopathy, the best research for preventing and treating tendinopathy revolves around strength training. It's what we call resistance training. It's any kind of external force that your system has to resist. So
Hmm.
people tend to think of that as strengthening. It could be body weight. A lot of it's body weight exercise. Sometimes it's bands. Sometimes it's dumbbells. But that type of exercise has the best evidence. Basically, it if you think about when you strengthen, everyone thinks about, it's obvious to them your muscles get stronger, but your
Yeah.
muscles attach to tendons, and a tendons attach your muscle to a bone. So when you put tension through a muscle, you also improve the strength and capacity of the tendon, and that's tendons are where tendinopathy comes from. So if your tendons are more resilient, they're less likely to develop tendinopathy. So at a base level, from a prehab standpoint, yeah, just being kind of intelligent about thinking about, okay, what are the tendons that most likely develop tendinopathy? What movements and muscle groups am I going to use in whatever exercise
Mhm.
program I'm starting? And then, for a period of time, as you're maybe before you even start that program or in the early stages when you're going slow, kind of like you're saying, gradually getting into it, it would be adding in some of those strengthening exercises that target the tendons that are most likely to develop tendinopathy. So there are things like the Achilles tendon, the elbow tendons, like the tennis elbow and golfer's elbow, the rotator cuff tendons, the patellar tendon on the front of your knee, like especially if you're doing a lot of jumping and squatting and things like that. Oh, the glute tendons. Glute tendons are a big one, especially I see lots of females with gluteal tendinopathy. So on the outside of the hip, people can imagine there's this kind of bone on the outside of the hip. We used to always think of it as bursitis, but a lot of females, especially around kind of the menopause stage, end up developing gluteal tendinopathy. So, but there are exercises you can do, strengthening exercises that target all these tendons and will make them more resilient. So just adding something like that at the early stages of your training program, or even like a few weeks before you start the training program, can do a lot in terms of reducing the chances that you get a tendinopathy and have those setbacks.
Yes. Okay. So let's break this down, because everything you just said was on my list of these are the common injuries that without fail. And so anytime someone comes to me and they're looking at my programs, I will always preface the conversation and I'll say, have you ever done like a foundation program or a general preparation phase or anything? Because it's great that, again, you want to start lifting, but have you ever, what have you done? And when they tell me their program, or maybe they haven't done anything, it always is patella tendon, low back, um, uh, the Achilles tendon, but like plantar fasciitis, elbow tendinopathies, rotator cuff. So that's pretty much. Do you find that synonymous in males and females, or do you see more in females, or what do you think?
They're really pretty close between the genders. I would say the ones that probably stand out to me a little bit more in females probably are like plantar fasciitis, the gluteal tendinopathy. The other ones, I wouldn't say in my mind they're pretty even between
Yeah.
the male and female.
Great. And probably, okay. So if we were to go to elbow tendinopathies,
Mhm.
how would you treat that once somebody has one? And can we do some of those exercises before? So just give an example of maybe a couple of exercises of
Mhm.
of what that looks like.
Yeah. So when you're thinking about tendinopathy in the elbow, most people are going to be familiar with the terms tennis elbow and golfer's elbow. It doesn't mean that you
Mhm.
had to get it playing those sports. It just tennis elbow is lateral tendinopathy. It's on the outside of the elbow. So and it has to do with our wrist and finger extensors. So they're the muscles that kind of lift your wrist up. They're on the top of your forearm. Those attach
Mhm.
on the outside of the elbow. And then on the exact opposite side of your forearm are your finger and wrist flexors, and those attach on the inside of the elbow. People will get pain at those two spots on their elbow. They'll either say it hurts on the inside of the elbow or the outside of their elbow. And so when you think about the research being most supportive of resistance training, if you had pain on the outside of your elbow, example exercises would be things like wrist curls. We call them wrist curls. So you're holding a
Mhm.
dumbbell, your arms kind of supported on a table so that your hand is hanging off the edge of the table. And then you're just holding a dumbbell and you're lifting it up and kind of squeezing your wrist extensors. Another muscle that attaches out there is our muscle called our supinator, and it turns your palm over so that your palm is facing up. We always just say like you're holding a cup of soup. So your palm
Yeah.
is facing up. So supinator rotates your forearm, but it attaches on the outside of the elbow too. So we do these banded exercises or even holding the end of a dumbbell where we have to rotate and strengthen supinator. So those would be
Mhm.
two examples for the outside of the elbow. The inside of the elbow is kind of just almost the exact opposite. You'd flip your forearm over so you're starting with your palm facing up, arm supported on a table with your wrist hanging off. You hold the dumbbell and you do these kind of wrist curls where you're lifting up and down. And then on that inside of the elbow, we have a muscle called pronator teres. And that one turns your forearm over so that your palm is down. So the same kind of idea, you use a band or a dumbbell to rotate and strengthen pronator teres.
Yeah. Perfect. Okay, and does grip strength play into that? Can that help that?
Yeah, big time. Grip strengthening is an amazing one. There's all kinds of grip tools like the little squeeze balls. There's the traditional grip strengthening devices. Yeah, especially it can help with both types of elbow tendinopathy, but it's going to be really relevant to the inside, on the inside of the elbow, because you're using your finger flexors when you squeeze something, and those muscles run up your forearm, and their tendon attaches on the inside of the elbow, on the medial epicondyle, that kind of bony spot on the inside of your elbow.
Yeah. Oh, well, that's the one. That's the one that I had of my client, and I was like, "This has got to go away. It's not
Totally.
going
They're
away."
so annoying too, right? Like you said this at the beginning, tendinopathies can last a long time. They can be super resistant. There's even some research showing that like plantar fasciitis study came out recently that said it can last up to a year in a lot of people. So,
Yeah.
and you hope that with rehab you speed that process up. But some people, I mean, I've had people over the years that it's hard, right? Because you have this thing that's annoying, but you don't want to give up the exercise that you love.
Yeah.
So and you wouldn't tell people to be completely sedentary and give it up. You're always trying to find that load management concept of like how much volume of exercise can they tolerate without totally flaring the tendon up. But you would never tell them to completely rest. That's what doctors used to tell people. And tendons
Yeah.
don't get better with rest. They will in the acute phases, they'll kind of calm down. But as soon as you stress them again, the tendinopathy will come back. The only way to
Yeah.
make it permanently go away is through gradual strengthening.
Mhm. Okay, so if we move down to, let's say, the, patella tendon.
Hmm.
So if someone were just coming in, there's I mean, you're the expert, so you tell me. I usually use, like, some isometrics, like a wall squat hold, something like that, but then also, like, more eccentric work with
Yep.
a heavier weight and then, assisting the leg back up or the arm back up and then going down again like that. Are those common approaches, or do you have any other ones that you would use?
Yeah, that kind of framework works really well for a lot of people with tendinopathy, where it's you start with isometrics. Isometrics are, if people don't know that, it's a where your muscle's contracting but your joint's not moving. So it'd be like if you imagine you did a bicep curl and you just held it halfway and didn't move, the muscle's still working, the tendon's working, but there's no movement. So the muscle fibers aren't changing in their length. And isometrics have kind of cool research showing that they kind of, if you hold an isometric for 30 to 45 seconds and you do 4 or 5 reps like that each day, it has a similar kind of effect to like taking ibuprofen. It's a hypoalgesic effect, so it kind of helps knock pain down. And it's really useful in the beginning stages when it hurts too much to move through full range of motion, but you can just have the person hold. So, like that patellar tendon example, doing a wall sit, everybody's probably had some experience with like wall sit and how brutal they are for your quads, but
Yeah.
they're a great one for isometrically loading your patellar tendon in those early stages. And then usually when people start to feel better there, then we'll go to like the eccentrics. And so that's where you're only doing half of the exercise. It's the part where the muscle fibers are lengthening. Our muscle fibers are all strongest with eccentric contractions. So if you imagine that bicep curl example again, it would be the down phase of the curl. So like you might put your arm in the top position, pass the dumbbell to your hand with the other arm, and then slowly lower it. And then when you get all the way to elbow straight, you take the dumbbell back with the other arm, reset. And so you're just, or like the squat, like if you're doing a patellar tendon, you would only do the down phase of the squat. That's the eccentric portion for the quads. So sometimes we do an exercise like this called a decline squat, or even a bench. Like I will sometimes give people an eccentric bench squat. So what they do is, say your right leg had the patellar tendinopathy, you'd stand in front of a bench, you'd do a single leg squat, you'd start standing only on your right leg, you'd lift your
Mhm.
left leg off the ground, you'd do a single leg squat all the way down nice and slow, sit on the bench, put both feet on the ground, stand back up with two legs. So the concentric part you do with both legs, and then
Yeah.
when you're at the top, you do the eccentric part only on the painful side. So the research has kind of changed. It's interesting. We used to always do that where we'd go isometric, eccentric, and then full range of motion.
Mhm.
Now the research is saying that the isometrics and eccentrics might not matter that much for a lot of people, and that you can just do heavy, slow contractions through whatever range of motion the person can do. So you might be modifying their range of motion, but the the key thing with tendons is that it's heavy and slow.
Yeah.
Like it has
Okay.
to be, yeah, that if it's too light, it won't create the stimulus for them to adapt.
Yeah, so quite different, a different tempo than muscles like a little bit quicker, but tendons really like that slow, heavy
Yep.
work. I love that. So if we move on to rotator cuff. So this is the biggest area for that I see for women, and mainly because of just the nature of female having breast mass in the front and nothing in the back. And so there's not a lot of I I see there's very, very, very few. I would say maybe 1% of females, maybe up to 3% that have good scapular mechanics, which then plays into clicking of the shoulder and all of this stuff, and then rotator cuff. It kind of goes kind of in the same family a lot of the times.
Mhm.
So, do you see that as well?
Yeah, for sure. That whole kind of all the biomechanics, the mechanics of the shoulder blade definitely can feed into people having rotator cuff tendinopathy. What happens, your rotator cuff is four muscles, and the one that probably 90% of the time develops tendinopathy is a muscle called supraspinatus that it runs across the top of the shoulder, and then it goes, if you feel the top of your shoulder, there's kind of a bone right at the top, and that's called your acromion. It's actually part of your shoulder blade. Right underneath the acromion is where the supraspinatus tendon runs. So it's got this kind of roof on top of it that protects it. But the problem is that there's only 1 centimeter of space there. So that tendon is in there. And when you lift overhead, we used to call it impingement syndrome. So people would
Yeah.
tend to experience this pain when they reach above shoulder level. And for a long time, the theory was that the ball at your shoulder, the ball and socket, the ball would sort of ride up and pinch the supraspinatus tendon underneath the acromion because there's only that 1 centimeter of space. And so for a long time, we called it impingement syndrome. It turns out it actually doesn't fully explain. Some people, that is a major driving factor, the biomechanics, but almost a large percentage of humans have some impingement on that tendon, and a lot of people don't develop pain. So it just turns out, like a lot of things in the body, it's more complex.
Yeah.
And now it's just called subacromial pain syndrome, but it relates to supraspinatus tendinopathy, rotator cuff tendinopathy. And it follows a very similar kind of treatment plan to the elbow tendinopathy and the patellar tendinopathy, where you're gradually you're gradually strengthening supraspinatus and its tendon. And there's specific therapeutic exercise for that. Just like we were talking about, this is like, you start to realize with each of these tendons, if you incorporate these specific therapeutic exercises that strengthen those tendons, you're going to be much less likely to have these issues when you get into a exercise program that is working on the big prime movers and not as focused on the little muscle groups.
Yes, 100%. So, do you see if we're looking at okay, somebody's doing they're either prehabbing or potentially they're rehabbing. What do you think? I guess this wouldn't work on the prehab side, but for the rehab side, what do you think of PRP injections? Are they helpful? Is it kind of maybe, maybe not?
Yeah, I think it used to be for a while, a couple years ago, I would have said, I would have been more likely to say they're kind of up in the air and we don't really have a lot of great research to know for sure. But I think PRP especially is coming around more, where I see more evidence supporting it for pain relief with different joint and connective tissue issues. So I often recommend to people, if they have a stubborn tendinopathy and they want to try something else, to try something like PRP, or if they don't want to do something invasive yet, there's something called shockwave therapy. Shockwave
Mm.
therapy is sort of like a really powerful ultrasound, and there is some research supporting it for like plantar fasciitis, resistant tennis elbow, um, some of the tendons that are a little more exposed that you can kind of hit with the shockwave. So that's another intervention that some people can try. Always in the beginning, the main thing is trying to modify their behaviors, work on that load
Mhm.
management, and then strengthen. And then if it's just really a frustrating case and it's lasting a long time and really interfering with life, then yeah, things like PRP and shockwave are worth looking at.
What about BP 157?
I still just don't see. It's funny, somebody just DM'd me yesterday about their peptide company, and I'm still not. I'm
100%.
not 100%. Yeah, even stem cell, I see a lot of pushback even from surgeons on stem cell. So I just don't think there's enough. I think a lot of that stuff is probably highly placebo driven.
Yeah,
And maybe peptides, I think there's probably a lot of potential with peptides. And I also don't sit around and read that research a ton. So there could
yeah,
be somebody might say, no, there's a great study on BP 157. When I wrote the book, we covered it in there. My co-author Glenn was super into peptides, and they're just at that time wasn't really compelling evidence for peptides yet.
yeah. So if we look at the different phases, so you have 3 phases in your book.
Mhm.
Can you talk about those and what we would do in each phase, what that would look like?
Yeah, I think it's a there's kind of three different phases you can look at, whether you're looking at healing or you're looking at treatment, and they kind of go together. But you know, when you first have an injury, people are going to go through an inflammatory phase
Mhm.
right away. So, and this is where you need that inflammation. Like we sometimes think of inflammation as bad, and like systemic inflammation that's there all the time isn't great. But when you first have an injury, you need inflammation because your immune system is coming in and sending macrophages and different cells in to clean up injured tissue and kind of remodel the area. So that usually lasts a few days. In that window, what would be kind of like the acute pain stage with people, we're doing a lot of things that are like soft tissue mobilizations, kind of like you might think of like self massage. So, like if you had plantar
Mhm.
fasciitis, it might be where you take a massage ball and kind of massage the plantar fascia on the bottom of the foot. Some people have seen that. Some people will take like a water bottle, like a plastic water bottle that's got frozen water in it, like and kind of do an ice massage on the bottom of your foot. Ice is even kind of changing where there's been some questioning of should we use ice in the inflammatory phase because there's been some research showing that it can slow the inflammatory process, which might slow the healing process. The same with ibuprofen, like ibuprofen, Aleve, these non-steroidal anti-inflammatory drugs, they slow the healing process. So we even now try to encourage people like if you can, the pain's not killing you, try to not take anti-inflammatory medication. Just let it go through its normal process. Implement things like gentle soft tissue mobilizations, gentle mobility exercises. Like if you had an ankle sprain, we'd have people kind of just do like the ankle alphabet exercises and kind of move their ankle
Yeah.
back and forth like the just keep it moving because blood flow is what you need. You need blood flow to come in there to bring oxygen and nutrients. So
Mhm.
that's kind of the first few days, maybe up to a week, depending on the severity of the injury. And then you move into more of like a fibroblastic type phase where the body's starting that rebuilding process. And so like that might be where like if you had a really severe injury, you start forming scar tissue and things like that. And or you had a muscle strain and the muscle fibers are healing, things like that. Or in that phase in treatment, we're starting to look at impairments. So does somebody have a range of motion restriction? Do they have a strength impairment? Do they have like a balance or kind of we call it motor control, like a motor, like an inability to coordinate and control their body? And so in the rehab world, and that's what in my book, the three phases of the program, phase one is focused on pain alleviation. Phase
Mhm.
two is addressing impairments. So you're looking at range of motion impairments, mobility impairments. So those would be stretches and mobility exercises. You might be using a tool like if it was your shoulder and it hurts for you to lift your arm to go through full range of motion on its own, you might use a golf club or like a broomstick so your other arm can kind of help guide that. Or sometimes people have seen wall crawls, like where you can kind of crawl up the wall and you're using an external object to sort of take some stress off of the painful tissues, and it
Yeah.
allows you to go. So you're just because like with the shoulder, okay, so here's a great example of females. Females are much more likely to develop frozen shoulder.
Yeah.
In a lot of cases, that starts from a rotator cuff tendinopathy. So, but what happens is people get rotator cuff tendinopathy, and then their initial reaction to the pain is to hold their arm like it's in a sling and not move it.
Yeah.
And then they develop frozen shoulder. So
Yes.
you have to keep the mobility going. And this is true with almost every condition in the musculoskeletal system. You want to respect the pain, but you have to keep the area moving. And so something like a rotator cuff tendinopathy will give people range of motion exercises that don't cause a ton of pain, but just keep them moving through as much range of motion as they can tolerate, so they're less likely to develop something like frozen shoulder.
Yeah.
And then the last stage of healing, the time frames can vary depending on the tissue that was injured, just because of blood flow. Different tissues have different supplies of blood flow.
Hmm.
But in that phase, kind of the last remodeling phase, it's focused mostly on strength training. You're trying to just build the musculoskeletal system, even though it's not simple like a car, it is very mechanical. And strength training has the best evidence for so many things because it makes all of your tissue stronger. Your bones get denser, you build muscle mass, your tendons get stronger, even your ligaments and the discs in your spine become more resilient with strength training. So it's really the best thing that you're doing at the end of rehab, and you hope the person will continue with because it's going to protect them over time.
Yeah. So if we look at pain specifically, and I know that you've been on a lot of podcasts and you've talked about pain, you have a chapter in your book about pain. This is hard because we know that there's a pain threshold that's different for everyone. I mean, I even without an injury, I will have some women in there that I'll be training and they'll be on the leg press and they're talking to me the whole time. And then all of a sudden they're like, I can't do another one, Haley. You didn't even slow down and you were talking to me unwinded the whole time. But in their head, they were tapped out. Like, no,
Mhm.
no, no, the pain's there. Like the second they feel anything. So let's talk about pain and what that looks like from a mental, like psychological component, and then actually how pain is.
Yeah. Pain is so fascinating. It's probably the thing I geek out on the most, but it's such a personal, subjective thing, which is why the treatment of pain, which is all I do, is very fun and kind of tricky because it has so many influences from what's the messages that you're actually getting from your body. Like we have these
Mhm.
little, they're called danger receptors. The technical term is a nociceptor, but you have these little nerve endings all throughout your body that detect danger. And if they're triggered to a certain level, they'll send a message to your spinal cord and up to your brain just saying, "Hey, there's danger down here. Pay attention."
Mhm.
So you have that side. You have all the messages coming from your actual physical body. And then you have all these psychological and emotional factors that go in, and pain is so interesting because we used to think pain came from your body. That was the old model. Like if you were sitting doing leg press and all of a sudden your quads start burning and then you have knee pain or it hurts in your quad, we used to think that was a pain receptor in that area sending a message to your brain saying, "Hey, there's pain here."
Yeah.
And that there's been a huge development probably over the last, I mean, 30 to 50 years, looking at, oh, pain is actually, you have those receptors, those danger receptors, but pain actually is sent from your brain. Your brain has to look at all these different things, your emotional state, your psychological state, what you believe about what's going on, your kind of like social support, like how um, threatened you might feel in the environment you're in. Does it feel like a dangerous environment? Do you feel safe there? Past trauma, nutrition, sleep. Like, do you have inflammation, systemic inflammation? Like maybe you have a metabolic disorder. Do you have like hormonal changes that are feeding into your immune system and your nervous system and how you perceive things? There's so many elements that go into pain perception and a person's pain threshold that it can be really tricky to help people navigate that. And so it's it is such an interesting, I have so many cases where, because I'm just talking to people and asking them about they're reporting their pain to me, and it's so interesting. Sometimes what people will tell you, you ask them on a 0 to 10 how much pain they experience, and like 10 out of 10, and they're just sitting there. If you were a 10 out of 10, you'd be like usually sweating, like it's like somebody stabbed you, like this is a life
Yeah.
or death. Like, so it's interesting what people will perceive from a pain standpoint. We've actually, in some ways, in physical therapy, tried to move away from just asking a 0 to 10 scale. Sometimes it's just like I will just use mild, moderate, severe. It just, because it's so subjective and personal, it can be challenging trying to figure out if you're only using pain to navigate things. It can be kind of a tricky, um, it makes it tricky. You almost need other objective kind of things you look at in the person, um, to determine how you move forward. But somebody who's exercising and saying that and is displaying no symptoms prior to that, and all of a sudden they can't do anything more. I think sometimes the psychological and emotional side of how something feels is a major driver. I think a lot of people stop because of mental factors and not because it's actually their physical body. It's amazing how far people can actually push themselves if they can get beyond the mental. Some of the best studies in the world on people who have the highest pain tolerance are endurance athletes. Endurance athletes, like people who run marathons and Ironman races and these 100-mile races, they have the ability to push past those messages they're getting and their brain telling them to try and stop. And I think not that you have to go be like that we all need to be like that, but I think it's something we probably need to keep in the back of our head when we're training. Like, is my body actually injured and I'm in like really severe danger? Am I experiencing a dangerous level of pain? Or is this just like I'm really fatigued and my brain's trying to get me to quit?
Mhm. That's interesting too, because you also see, um, people identify with, if they've had back pain. I mean, I had back surgery when I was 17. I was a
Mm.
gymnast too,
Yeah.
and I had back surgery at 17, and I could very well now, just be like, "Well, I have a bad back.
Hmm.
I have a bad back. I've always had a bad back." Do you see that too, that you like somebody really identifies and they're just like, "No, this is what I have and this is who I am."
Hmm.
And so then it plays into that, feeds into that loop of, "Oh, maybe I have pain." But talk about, so there's been multiple MRIs
Hmm.
that you pull a bunch of people off the street, and half of them you look and think, "Well, you probably shouldn't even, you should be in significant pain," but they don't know any different, and they aren't mentioning it. But what does that look like? I mean, that's a whole psychological component too, or
Hmm.
what do you think of those studies?
Yeah, I mean, the first part you said is so true. The psychological piece is something I spend a lot of time trying to talk with patients about because some people have such limiting beliefs about pain. And that one you mentioned is a huge one. Like, I've had an accident when I was earlier, so now I'm going to have a bad back, or I got in a car accident, I hurt my neck and it's just always going to be this way. Or my parent had back pain, so I'm just doomed to have it because they had it. People have these very limiting beliefs around pain. So I spend a lot of time trying to push back on those gently with people and just kind of plant seeds on just helping them understand pain. I think helping people understand what pain is and how the pain system works can help them sort of reframe. It's a big part of like the treatment of pain is helping people reframe how they think about pain. And so, that component is so huge. And the MRI studies, there's tons of MRI studies. I highlight these all the time. They basically take asymptomatic people, so these are people without pain, bring them in, do an MRI. They've done these on the shoulder, the knee, the spine. So, and it's almost like half of the population have things like meniscus tears, disc herniations, and disc bulges, labral tears in their hip and shoulder. And these are people without pain. So it's ranges from 30 to like 45% of the population have these things. And so when people, we actually are very apprehensive to have people get MRIs now in rehab because there's been studies showing that when people have an MRI and they see something on it, they will kind of instantly worry about it. And that worry will negatively impact their outcomes in rehab. And it's been shown that now we know almost half the population has these. So there's no way to prove that that thing you see on an MRI is the cause of your symptoms. And it
Yeah.
doesn't really change what you do in rehab. Now, if you had like these really severe symptoms where you're more of a surgical candidate, then an MRI is useful. But I kind of tell people now, like, don't go get an MRI if you're not planning to have surgery, because
Yeah.
what we do to treat that is going to revolve around your symptoms and how you move, your mobility, your strength, your symptoms. I'm not basing my treatment on that MRI. It's really on how you function. So people just have to, a big part of the education we work on with people now is separating pain from injury, because most people have this belief that pain means something's damaged in their body. And in a lot of cases, that's not true. You can have pain and absolutely no injury. There's a lot of people who go have MRIs who have severe back pain and have nothing, no findings. So that's equally as discouraging actually to a lot of people, because they're expecting to be able to blame the symptoms on something. And then you can have people who have severe injuries who don't experience pain. You have lots of these stories from like situations like with different athletes where they're like in the heat of the moment in a sport and break a bone or something and don't even they tear a tendon, they don't experience any pain. You hear lots of stories of this from like soldiers in wartime situations where something really severe happens, they don't experience pain at the time. And you can think of less severe things too, like all of us have probably like woken up and saw a bruise and we don't remember anything ever hurting or how we got it. So
All
that's
the time.
yeah, that's an injury. There's injury, the injury happened and your tissue's healing, but you don't recall having pain. So pain and injury are different things. And I think the main thing for people to know is that pain does not always mean that something's damaged in your body, especially when you're talking about something like tendinopathy, which so many of us are going to have. Like tendinopathy is not, you wouldn't really categorize that as an injury. It's more of a pain condition. It's more of like a sensitivity. It's not a, like you actually damage something.
Okay, that's a super important part. If we move down, so one other area that I want to talk about, the feet.
Mm-hmm.
So the feet, there's a lot going on there, but also, I'm going to lump like ankle in there as well.
Yeah.
This is a commonly weak spot that I see in women as well, not only with maybe a tendinopathy or without, but it's the balance, the proprioception and the balance that starts to decline as we age as well.
Mm-hmm.
And, do you recommend like when weightlifting, like a minimalist shoe, barefoot? Do you prefer a padded shoe? What's your advice on that?
Yeah, I think at the end of the day, you have to kind of figure out where your starting point is. If somebody's never worn a minimalist shoe or done a lot of training barefoot, I think you just also have to think of it like you're the rest of your training. You have to gradually get into it and give your tissues time to adapt to it. But I think ultimately, I'd love to see people doing most of their training in a less supportive shoe, something that's more of a minimalist style. I mean, I grew up only doing things barefoot. So like I have all these weird muscles on my feet. I'm sure you do too from gymnastics. Like I have weird hypertrophied muscles on my feet because I was always barefoot and holding my foot in funky positions, especially like in martial arts, I'd be kicking and you have to hold I just did a lot of foot training. I didn't even realize I was doing a lot of foot training. But I think, if you're someone who's been in a really supportive shoe, the problem with really supportive shoes is that they feel great and they might be useful for like a really stressful competition. Like if you had to go run a marathon or something, maybe you use it in an event. But in the rest of your training, the problem with those types of shoes is that they support you so much. It's almost like having a brace on your foot. And we know we wouldn't brace other parts of our body because we know the body atrophies and deconditions. That's why you don't want to be in a sling for too long or have a knee brace on for too long. You're not having to use your neuromuscular system as much. And so people don't think of that with their shoes because we're just so conditioned to just, oh, you just wear shoes and that's what you do. And I think more people are becoming aware as more of these minimalist shoe companies are coming out, and we're seeing more research showing that just even wearing a minimalist type shoe or being barefoot helps to strengthen your foot.
Mhm.
And you think about females, like females are more prone to something called posterior tibialis tendon dysfunction, where their tibialis posterior muscle, its tendon can basically sort of break down, which leads to progressive flattening of the arch. So you hear this sometimes in females around kind of menopause timeframe, where that tendon related to hormonal changes, the tendon kind of starts to deteriorate and degenerate, and their arch gradually flattens. And so I think there's a place for all humans as we age, but especially females, to be incorporating movements and exercises where you are challenging your foot, whether it's barefoot or being in a less supportive shoe. But just
Mhm.
think, I just have to gradually work into it. It might not. You probably don't want to just jump straight into one of those a shoe like that if you're not used to it, because it will end up causing probably a lot of arch and foot pain.
Mhm.
So you have to gradually give the tissue to time to change. If you were going to switch over to like, say like, okay, I want to start using minimalistic shoes for most of my daily activities, well, you might only be doing 15 minutes at the start, or maybe an hour in the day, and then you go back to your other shoe. Like you're just trying to slowly build up that capacity.
Yeah. And this is all, again, this is all in your book. So let's move on to your app. Can we
Mm.
announce that? Can we
Oh,
start
yes,
talking
please.
about
Yes,
that?
yes. Thank you. Yes, I'm so excited about it. I think it's going to be, the book has been out 2 years and the book has helped a lot of people, but the feedback I always get when it comes to exercise and movement, it's helpful to have video. And I think this is why
Yeah.
like my YouTube channel and Instagram account are so popular is it, it's okay to have pictures, but a lot of people just ask me like, could I get rehab and prehab programs in video format? A lot of times people just want like a exercise library. Like we were talking about these exercises, like imagine
Yeah.
that'll be a part of the app where it's like you can go in and just find exercises for your foot and ankle, like that you could
Mhm.
just incorporate to work on mobility and strength. And so that'll be a big focus of it for me, is to just create these video-based prehab and rehab programs, so that people can start working on these things before they begin a program. Most of the people will probably come once they're already in pain and injured. But a lot of the education for me is like trying to get people to think about rehab exercises as not just rehab, that you can keep doing them after to reduce the chances that it comes back. So yeah, I'm
Yeah.
pumped about it.
That's awesome. And when do you anticipate the app to launch?
I think it's gonna take about right around like 45 to 60 days. So I'm hoping that 2 months max. So maybe sometime in October.
Okay. Well, good. Keep us posted. In
Yep.
the meantime, I'm super bummed that our time is almost up. But in the meantime, I mean, this again, I'm gonna show the book for anyone who's watching. This book is incredible, but as you said, the app is so nice because I'm not lugging this to the gym,
No, that's the problem.
but it just, I mean, it literally breaks down every single tendinopathy or issue, and I have used it so much for just flipping through and saying, okay, well, this breaks it down, tells me exactly what to do in phase one, phase two, phase three. So I love it. Where can people find you right now if they're not familiar with you? I did mention your Instagram, but at the first, but go ahead and just tell us where to find you before the app comes out.
Yes, thank you. I'm at Rehab Science, mostly on Instagram and YouTube. So Instagram's kind of quicker. If people are on that platform, they know it's kind of quicker. I have a lot of posts that are just like exercises. Like you could find a plantar fasciitis post, kind of flip through carousel style and find exercises for that. YouTube, I do a little bit more. I'm narrating, talking through the exercises, so it's just a little more detail. But they're both Rehab Science. The book is called Rehab Science. It's on Amazon and Barnes and Noble. My website is rehabscience.com. So people can find me in any of those places. And if people want to like DM me on Instagram and tell me, say, hey, I came from the podcast today, that really helps me have some context. But I try to answer DMs. So happy to help people, because sometimes like on that platform, it's hard to find a post that relates to what you're looking for. YouTube is
Mm,
a little bit easier because I have playlists. So you could go to the hip playlist or the ankle and foot playlist or the elbow playlist. And you can, all the conditions we've talked about today, I've covered these all in videos, and there's exercises you can just start with. And like I said, the book is like a textbook, so it's a little bit, that's the annoying part, is carrying it to the gym, but it's a lot of people use it as a home reference and they just flip open and it's like you've
yeah,
got 3 phases. You have a program. You don't have to go do the PT. You save the money on going. It's like $38 on
yeah,
Amazon. It's like one copay and you have a
yeah.
resource that you can treat your whole body with.
Oh, Tom, it's amazing. And so I'm guessing that the app is going to be called Rehab Science too.
Yes, yep, same.
Okay, awesome. Well, I look forward to having you, as we had discussed before, in something special for my audience. But thank you so much for what you're putting out in the world. Thank you for your expertise, and I have to say, you are such a nice guy, and that is so refreshing in this space. It's so refreshing in the fitness kind of arena for someone like me who's seeking out guests. So thank you for your time today and your expertise, and we look forward to having your app come out.
Thank you so much. Hey, it was a pleasure to be on. I hope this helps everyone in your audience. And yeah, thanks again.